like to welcome you to today's panel, Meds to Beds, Optimizing the Retail Pharmacy Experience. My name is John Stevens. I'm the Director for Client Success for the U.S. North and Canada here at Get Well Network. And during today's session, you're going to hear from presenters from Dayton Children's Hospital and Gundersen Health Systems. They will share their experiences on leveraging the tools and feature sets within Get Well Network, not only to increase their pharmacy revenue, but to help improve patient satisfaction. You'll hear from our presenters today on how they've collaborated with their Get Well Network team to build and refine their patient experience, leverage integrations with their EMR, increase patient and family participation, and see a positive return on investment. After hearing from our presenters, I'll open the floor to let you ask questions to share your experiences with leveraging Get Well Network and partnership with your retail pharmacy and Meds to Beds programs as well. With your participation, this session will provide a great opportunity to exchange ideas and best practices. It's my pleasure to begin this afternoon's presentation by introducing our presenters. Our first presenter, Greg Bader. Greg has been a nurse at Dayton Children's Hospital for 9 years and manages clinical technologies which includes Get Well Network. Following Greg's presentation, we'll hear from Dr. Rebecca Neindorf from Gundersen Health System. Dr. Neindorf is the lead pharmacist in transitions of care at Gundersen Health. She primarily staffs the outpatient setting and participates in the development and implementation of patient care services in both outpatient and inpatient settings. Her work is focused on optimizing Gundersen's bedside medication delivery program, which includes medication reconciliation and patient education. The program helps patients get well and stay well in their transition from hospital to home. So before we get started, I need to share a disclosure statement with you related to the nursing education credits that's being offered for this session. I bet you all have not heard this at all this week. But if you have, I'm going to read it to you again. The Maryland Nurses Association is an accredited approver for continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. If you wish to receive credit for attending this activity, you must complete the session survey found on your conference mobile app. In this survey, it's very important that you check the box that indicates you would like to receive credit, enter your full name and email address in the space provided, and your certificate will be sent to that address. In compliance with the continuing education activity credit conflict of interest disclosure requirements, we'd like to announce that the presenters of this session have no commercial association that would create a conflict of interest. Greg Bader from Dayton Children's Hospital is going to kick off our session today. It's all yours. Welcome, Greg.
Thank you. Good afternoon. So I'm going to start with reviewing what I'll talk about today, which is how to increase strategies to increase utilization of your retail pharmacy experience, define how utilizing Get Well Network's Med to Beds pathway can decrease patient and family stress and improve your patient experience, and talk about how integrating with Epic can improve your utilization of your Meds to Beds program. So a little bit about Dayton Children's Hospital. We are a freestanding children's hospital situated right in between Nationwide Children's and Cincinnati Children's Hospitals. We're 184 beds, including a 24-bed inpatient behavioral health unit that was just opened this summer. We have 2 emergency departments, which see about 98,000 visits per year. We just a couple of months ago became level 1 trauma certified. We have 2 urgent cares, and just this week we now have 3 Kids Express locations, which are like minute clinics for pediatrics specific. We are magnet designated with a little over 1,100 nurses. So for our Meds to Beds program, we began a pilot of the program in April of 2019 on 2 of our inpatient units, our HEMOC unit and our 8 specialty peds unit, which consists mostly of respiratory and GI patients. In July, our pharmacy team had met with me and wanted to discuss how we could utilize Get Well Network to improve our experience. So we met with Nakia, our client service manager, to talk about how we could implement Get Well Network's Meds to Beds pathway And when we met, we kind of talked through, we would plan to do a kind of a two-phase rollout, one phase being an improved favorite space with improved content on our pharmacy. And then secondly, being an integration with Epic. So as Nakia had talked to us, she mentioned we got a lot of talking about how do we in the pharmacy get information back from our patients that they want to be enrolled in Meds to Beds. And she said, well, it's easy. We can send you emails or Vocera messages or anything. And of course, our pharmacy said, yeah, we don't like either of those options. We want everything to remain within Epic. And so she, of course, said, well, I don't think anyone's doing that, but that's a great idea. Let's do it. So she moved forward with trying to talk to her leadership about that. Around September, we started talking about interface meetings. And in November, we were finally able to get kind of everyone on board with the idea. And from there, it moved very quickly. By the end of November, we were testing interface messages with GetWell Network. And come mid-December, unfortunately, our marketing team didn't quite move as quick as we initially wanted with our pharmacy content, so we didn't end up doing a two-phase thing. We did everything at once. But on December 17th, we went live with our new favorite space and live with Meds to Beds with one patient, which went extremely smoothly. So we said the next day we would just turn it on for everyone. So how our Mensa Vet Pathway works is when a patient is admitted to either of these two units on the admission database, the nurse will ask them if they would like to be enrolled in the Meds to Beds program. If they answer yes during that time, GetWell Network will still give them a prompt once they get into the room, giving them more information about the pharmacy, telling them that they'll need their payment and insurance information ready, and so on. Where we really came in then was on those patients that either answered no or not that your nurses would ever do this, they just didn't ask the question and didn't document anything, right? So 6 hours after they're in their inpatient bed, if either of those have occurred, then they'll get the GetWell Network prompt asking them if they would like to be enrolled in Meds to Beds. And then that prompt will document back into the Epic admission database flow sheet row to notify our pharmacy. So in the short time that we had live before this presentation, our new favorite space from December to February had 139 clicks on it. And with our prompt during that time, we saw that 31% of our patients responded yes to that prompt or family members. 20% of them had responded no thanks. And 49% of them responded not right now. And so interestingly, when I looked at that not right now, of those 69 responses, 5 of them converted to a yes later on, and 7 converted to a no later on. But unfortunately, 57 of them remained a not right now until they were discharged. So I'll talk a little bit later how in our future state we had decided we really kind of wanted to change that not right now. We thought maybe that was kind of a misleading answer, and ultimately changed that to an ask me later. We went live with the ask me later question on February 14th, and just before I came to the conference, I kind of checked that out. And unfortunately, I haven't seen the response yet that I would have liked to have seen, but we did improve a little bit. During that time frame, 37% of patients said yes at the time. 20% said no. We still remained with 43% saying ask me later, and unfortunately only one of them converted to a no. But it hasn't been live for very long, so I hope to see that will improve. So this is looking at on our 8 specialty peds unit, which was again respiratory and GI patients. On the first star to the left, you'll see is when our Meds to Beds program went live. Fortunately for us, we've always had a pretty high utilization of our retail pharmacy. Interestingly, when we started the pilot, we were seeing a kind of a lull at that time. But then with the second star that you'll see towards the end is when we went live with the GetWell Network conference or content, and we had a nice increase in our retail pharmacy capture there and a nice decrease in our filled out at outside pharmacy prescriptions. This is showing our overall percentage of our medications filled by our retail pharmacy for the 8th floor, which again has remained pretty high for that unit. And for our HEMOC unit, interestingly, we saw as we get to the 2nd star, as again, when we went live with the Get Well Network content, we increased our fills within our pharmacy. But at the same time, we also actually saw an increase in our outside pharmacy fills. And I think that's related to a couple things. We've had an extremely busy winter, as everyone has. So I think that has some effect on it, as well as we've had some internal challenges with our Meds to Beds program, and specifically in our HEMOC unit, where we have a lot of consultants coming in and ordering medications maybe later in the game than others and things. So it has gotten a little bit confusing for the staff sometimes and the families, and ultimately ends up in them going to their normal retail pharmacy. So unfortunately, while we've seen their percentage overall decrease when we combine the two units together, we have still seen an overall increase in our pharmacy utilization, and hope to see that increase in the future. So as we talk about our challenges and next steps, we, in the last month or so, we have kind of decided to regroup this. Prior, it was really being managed only by our pharmacy team, and it realized we needed a little bit more substance behind that. So myself and our informatics team kind of took over to help our pharmacy team. We really worked through. They were expecting a lot of this to be owned by nursing, and that's a lot of people to try to get to own it versus being owned by our pharmacy. So they've started taking more ownership of it. They now, as soon as they get a patient enrolled in the retail pharmacy experience, they're actually reaching out to the families, making sure that they actually want to be enrolled in it, talk to them about the process, and then touching base with the nursing staff, making sure they understand that patient's enrolled in Meds to Beds and what to expect throughout that process. We've also made a lot of changes to the nursing workflow, including where we've added Meds to Beds icon to the nurse brain in Epic. We've created banners within an Epic that are dedicated to the pharmacy response as they're in Meds to Beds. So one dedicated banner will remain on those patients' records with updates as they go through the process, telling them that they've been enrolled and verified by the pharmacist, then that prescriptions have been received, or the pharmacy needs verified, because sometimes, unfortunately, they'll say they're enrolled, and then maybe a physician will go in and ask them what's their preferred pharmacy, and they'll say, well, it's the Walgreens right down the street from me, and so they'll change it. And that gives us an opportunity to go back and check that preferred pharmacy and make sure that we are really getting those prescriptions filled with us. Again, as we talked about changing that not now to ask me later, and I hope to see that will increase our response rate. And then we've really decided that throughout the busy season, as well as we just realized sometimes, even when it's not busy season, when you have a bad trauma or things, you start to get a lot of staff pulled. And we just need a backup plan for, okay, maybe we can't bring the meds straight to their bedside, but we need to make sure that we're giving the best experience for them. So we've created a dedicated space in our retail pharmacy so that even if for some reason we can't get the meds up to you to your bedside, we can tell you, hey, we're going to have you come down to this exact spot. You're going to skip the line, and we're going to give you your meds right down at the pharmacy. So we have just put all that in place in the last couple of weeks, and hope to see that improve. Our goal is to have it rolled out to the rest of the hospital by the end of this year. And they actually just had a meeting yesterday to discuss, and I got a timeline that will hopefully have it rolled out to the rest of the hospital by June. So we're looking forward to how that'll continue to roll. Thank you.
All right, well, good afternoon, everyone. I'm Rebecca from Gundersen Health System, and today I'm going to be talking to you about how we optimize the Get Well network to improve the efficiency of Meds2Go, our bedside medication delivery service. So first of all, I always love to show this picture at presentations. This is our main campus of the Gundersen Health System along the beautiful Mississippi River. We are an integrated health system serving 19 counties in 3 states. We're a multi-specialty group medical practice. We're a teaching hospital. We have regional community clinics and hospitals. We have 325 licensed beds, and we have 400 Get Well network locations. So to begin, I'd like to give you a little background on Meds2Go, the service itself. So again, it's a discharge medication service for Gundersen Health System patients who are discharging home versus, say, to a long-term care facility in select units. So the units that we're currently servicing are cardiopulmonary, pediatric, orthopedic, neuroscience, and inpatient rehab. The goals of this service are to increase patient satisfaction by providing a convenient medication service at bedside at discharge. We also strive to decrease adverse drug events and then certainly decrease readmission rates. So we have several patient touch points with Meds2Go. First of all, we, of course, use the Get Well network, and this is where we introduce patients to the service, give them information about it, and then it's an interactive tool where the patients can choose to enroll or decline enrollment by interacting with the Get Well network platform. We also reach patients at their pre-admission appointment, so if they have planned surgeries, say for example, a total joint replacement surgery, at their pre-admission appointment, they're introduced to the service. At that point, they can decide if they'd like to enroll. We have pharmacy technicians that help us with the service. We have a dedicated Meds2Go pharmacy technician who really kind of coordinates the whole thing, and that technician will go room to room to interview patients for enrollment for those that haven't enrolled through the Get Well network or through the pre-admission appointment. We also work with a hospital pharmacy technician who does our medication histories, and if that technician is in a room with a patient who would be eligible to use the service, being on our unit, discharging home, then they will ask them if they'd like to enroll. And then our Meds2Go pharmacy technician will coordinate payment and delivery of the medications. Finally, we've got the pharmacists. We have the inpatient pharmacist who has been monitoring the patient throughout their admission, and at the time of discharge, they will go through the patient's med list, making sure that everything is appropriate and accurate. And then we have the retail pharmacist who will then put the orders together and will bring them to the patient's room where the patient will get a thorough bedside medication consultation. So of course, as we've been providing the service, we've been evaluating barriers to enrollment, and these are some examples of what we've identified and what we've been trying to work with. So we believe that a lot of times with the Get Well network, patients would choose no just to get the prompt off their screen because maybe it was interrupting their television time or whatever. Maybe they didn't quite understand it and it was just easier to get rid of it. Patients thought they were changing pharmacies, and they have a lot of loyalty to their home pharmacy as we want them to have, and so they were reluctant to change, even though that's not what we were asking them to do. Of course, they're concerned about costs. That's always an issue. The timing of the prompts maybe weren't as beneficial to capture the patients as we'd like. And then the patient population. When we were first utilizing the Get Well network to enroll folks in Meds2Go, we were limiting ourselves just to the cardiopulmonary unit. And of course, folks on that unit are quite sick, and oftentimes they're elderly, maybe not as tech savvy, so that was certainly another barrier that we were looking at. So with those barriers in mind, we decided to make some changes with the prompts in the favorite space to hopefully capture more patients. So we work closely with our patient education folks in the Get Well network to improve both the language and the format of the prompts in the favorite space. So what you're seeing here is an example of the prompt. First of all, we changed the time of our prompts to 8:30, 11 a.m., and 3 p.m. Prior to that, we just had 2 prompts, and instead of an 8:30 prompt, we had an 8 a.m. prompt, which oftentimes coincided with rounds, so patients were busy talking to their providers, their nursing staff, and weren't seeing the prompts. So the first prompt, as you can see, we really kind of hit on the points that we felt were very important to the patients. There is no extra fee, and your regular pharmacy won't change. So with that, the patient can either choose yes or tell me more. Previously, they could choose yes, no, or tell me more. But we decided we didn't want to give them the option to decline until they let us tell them more. So if they click tell me more, they get to the next screen, which says, why use meds to go, and kind of gets more into the weeds, and it's for your safety. You'll get one-on-one counseling, just kind of more information. At that point, they can choose yes, no, or later on, we added a video, and so now they can choose to see the video. So this went live in July of 2019. I'll talk more about the video in a little bit, but that went live in October. So these are the prompts. In addition to the prompts, we have the favorite space optimization. So as you can see on the left is where Meds to Go sits on the favorite space. So they click on that, and then we kind of created a cascade of slides, trying to be like a kind of FAQs, frequently asked questions. So the first slide would come up and just give a general overview of Meds to Go, at which point they could say yes or I want to learn more. And then if they say learn more, they'll get to the next slide, and that may focus on the cost. If they still want to learn more, then they'll get another slide that'll focus on, will my pharmacy change? So each one kind of focused on those questions, those barriers that we had identified previously. The final slide then also says, gives them the choice of saying yes, no, or they can watch a video. So the video. I don't have time to show you the video. I wish I did, because we're really proud of it. But at the bottom, there's a link, so if anyone wants to watch it, you can find it on YouTube. But the video is great because it really summarizes everything that we want patients to know about Meds to Go, and they can actually kind of see it in action. Lets them know about the benefits, shows them the process, and then, as many health systems are doing right now, Gundersen is also really focusing on combating the opioid epidemic. So we took this as an opportunity to also throw in a little blurb about drug disposal information and explain the importance of it and how to do it. So this went live in October of last year, and from October 1st through January 31st, we had 78 patients start the video and 46 patients complete the video. All right, so now to the metrics, to the nitty-gritty. So we wanted to see how these changes were impacting the service, how they affected our outcomes. So the first thing we looked at was the percent enrollment into Meds to Go by service. And so this is just all of 2019. And by service, I mean who's enrolling the patient. Is it the Meds to Go pharmacy technician? That's in blue. Is it the pre-admission or the med history technician, or maybe even nursing staff? Anyone else? That's gray. And then the Get Well network is, of course, purple. So as you can see at the beginning of 2019, it was almost exclusively the Meds to Go pharmacy technician who was enrolling the patient. That means they're going room to room, asking the patient if they want to enroll, giving them information about the program. As the year continues, we start seeing more gray, because that's when we started implementing the pre-admissions and the med history tech to help us. But as you can see, the blue is really going down, especially towards the middle of the year when we made these changes, and the purple is really going up. So by the end of the year, the majority of our enrollments are done by interaction with the Get Well network, and hardly any are done by our Meds to Go techs, which is great. If they're not in the room with the patients enrolling, they can really focus on the discharge, and that's so important, to improve the efficiency. So that was great, really helpful. The other thing we looked at was Get Well network yes responses. So as you can see at the beginning of 2019, there weren't a lot of yeses, but as the year went by, it really creeps up. But I gotta be honest with you, in July, not only did we go live and make these changes with our format, we also added the ortho and neuro unit. So to really be fair, are these Get Well network yes responses because of our improved format, or is it simply because we're on more units? And that's why I broke it up into the different units. So purple represents cardiopulmonary, gray is neuroscience, and green is orthopedics. And so the purple really has gone up, especially towards the middle of the year. It starts going up. So to me, that really speaks to the fact that those changes did have an impact. So that was great news for us. And then some other metrics that we look at are total enrollments, total prescriptions filled, and total revenue. And I just went from 2017 through 2019. We actually started Meds to Go in 2015 as a pilot, but 2017 is when we began to collaborate with the Get Well network. So that was the time period I wanted to focus on. So as you can see, total enrollments in 2017 were just under 1,000, but went to over 2,200 at the end of last year. Total prescriptions filled went from about 2,600 to 4,400 at the end of 2019. And then revenue, which keeps the lights on and keeps us here and allows us to expand. Wow, that almost doubled from right around 93,000 to 217,000 at the end of 2019. So pretty cool stuff. All right, so feedback and future plans. So our successes are definitely patient and staff satisfaction. We know that anecdotally, our patients tell us every day when we're bringing the meds to their room how happy they are. They don't have to make another stop on their way home. They don't feel well. They just want to work on getting better. And so they're so happy that we've got it all wrapped up for them. And then the staff are really on board. They really support us, and we know that because they tell us, but also because they encourage patients to enroll. And last year I worked with our Service Excellence Department, and we actually kind of did a retrospective study of patients over the previous 15 months. And those who participated in Meds to Go, it resulted in I had to write this down, in a statistically significant positive impact on patients' experience of care versus those who did not. So that was really cool to actually have the numbers to go with what we knew was true. So with these changes, we've definitely improved our efficiency, like I showed you with the graphs. And because of this allows us to expand. And which makes our leadership really happy is we've been able to expand and stay payroll neutral. So we haven't had to add any FTEs. We've been able to just keep growing without more people. So that's been great. And because we're more efficient, we're not just putting more and more work on the people. This is work that they can handle. It's sustainable. So that's great too, because we don't want to burn people out. Barriers. We are not currently enrolling people into Meds to Go using the Get Well network on all units. One that we're not is pediatrics, because we were thinking, these are minors, and we need to have caregivers, an adult present to do so. But as I'm here with Dayton and see that they're a children's hospital and they're making it work, I think that we may have more options, so I will have to look into that. And then we're also not using it on the inpatient rehab unit, and that's because of staff requests. The folks on inpatient rehab often have some cognitive impairment. They thought it might be kind of confusing for them, but we can certainly look at that again in the future. Manual input. So when a patient interacts with the Get Well network and says they want to enroll or not enroll, our techs get a text page that they then have to put into our EHR, which we use Epic. So it's not as seamless as we would like. We'd love to have it be a direct interface. Service hours are limited. We're 9 to 5 Monday through Friday, no weekends, no holidays. We wouldn't be able to remain payroll neutral with that expansion, so that's something that we're kind of waiting and seeing on. Next steps, we want to expand hospital-wide. We're looking to be in another unit this summer, and hopefully by the end of the year, 2 more units. So we're 1 unit at a time getting there. It's a little slower than we had initially anticipated, but we're getting there. And then, yes, we would love that direct interface, and I said 2 years ago I was here talking about how much I would love to have a video, and that seemed like reaching for the stars, right? We got the video, so I think we can get this direct interface. I'm feeling pretty confident about that. So that's it. Any questions? I don't know if the link would work. Yeah.
All right, okay, I'm coming.
He can try it. He said he could try it.
Yeah,
Oh, hey, by all means, yeah.
questions and then watch the video?
I don't know. What is your audience going to do? I'm sure.
What would you guys like? Do you want to watch the video?
Yeah,
or do
Joe.
questions?
2016, that one slide, you said, is that your question? 16, 17, 19 data?
Oh, I'm.
I could ask you to go back to the data side. That's actually going to be a precursor for my
Oh, yeah. Oh, yeah. We can do that.
I have another microphone. That's okay.
This one?
I actually have lots of questions.
Oh gosh.
Oh, you
Okay.
need the mic.
I'll do my best.
Joe, you need a mic.
Got it. Okay. So the 217,000 in revenue, this is gross revenue?
Yes.
Okay.
Yeah. Does not
And
include.
Is
does
this
not cover
this is
cost.
actual revenue or based off of an average prescription fill?
No, it's actual revenue.
Okay. And is this revenue that is specific to only those patients that said yes and enrolled in Meds to Go, or is this include
Yes,
some
this
other
is-
population?
This is only patients who actually received the service, so that we actually did go to their room and deliver their meds. Because there are many patients that enroll, but then they discharge outside of service hours, and so they may get the meds from us, but they weren't in the service. So this is just patients who we delivered the meds to their room.
Got it. Yeah, that is incredible. Did you see any incremental need to add staff to support the delivery or to support the initiative?
We've only ever had one dedicated pharmacist and one dedicated tech on the service every day. So during the service hours, we only have one pharmacist and one tech. And that was kind of based when we were researching the service and looking at other institutions that were doing it. they were able to do 4 units with that. So that was kind of what we were looking at. And so initially, there wasn't enough work to really keep us busy. So then
Right.
the staff would help out in other ways in the pharmacy, just doing kind of regular workflow things. As it's expanded, there's certainly been more work to do. We've still been able to do it with just those 2 staff. However, we do get some kind of outside help. For example, the prescriptions are run through the regular pharmacy, so the technicians that are on the floor in the regular pharmacy will be processing prescriptions for meds to go, as well as the patients that are standing in front of us at the counter. So they're helping us. We also get a lot of help from our learners. So we often have a pharmacy student with us, and the difference between when we have a student and when we don't is pretty dramatic. So we get by without, but it can be tough on those days when we have, say, 16 discharges. But an average, we do about 10 a day.
Right.
So we'll sometimes even pull pharmacists off the line to help if it's getting really busy.
Yeah, and I guess that kind of goes to the heart of my question. So you added on the revenue side without having to add any in the overhead.
Mm-hmm.
It's fantastic.
Yeah.
So then the last question, I promise I'll go to someone else. So typically when we're talking about this workflow, there's 3 outcomes that we're focusing on. So one is the revenue, and you clearly hit on that.
Mm-hmm.
You touched briefly on the impact on patient experience. I'd be
Mhm.
very curious to know more about that. But the third, and probably equally important, is the ability to keep patients out of the hospital, right?
Readmission.
I mean, if you
yeah.
think of what you're doing, you're actually
Mhm.
sending a patient home with the medications they need to stay home and not come back.
Right.
So the medication non-compliance becomes a non-factor.
Mhm.
So I'm just curious, do you intend to look at that as well at any point to see, of those patients who went home with scripts in hand, as a population, did their readmission rate reduce compared to those who didn't take advantage of the service?
We have been looking at that, and unfortunately, we haven't been able to move the needle like we wanted to. We spent so many years just on cardiopulmonary without being on any other units. I mean, before we brought neuroscience, and we've been on cardiopulmonary over 3 years. And we found that the readmission rate stayed pretty much neutral, which was really disappointing because we'd heard
Yeah.
of other institutions being able to drop, and we were wondering why. But that's somewhat because we started with cardiopulmonary, and these are the sickest of the sick oftentimes, and they are repeat visitors no matter what anybody does because of the condition they have. They have to keep coming back in and kind of getting tweaked.
Yep.
So we continue to look at it, but we haven't been able to move the needle as we'd like. Our ortho folks, they typically are healthy when they go in. They're going in for pre-planned surgery, so they weren't going to come back anyway. Although of course, we're concerned about the infection rates on readmission. But so we're looking at it, but we haven't been able to move it in the direction that we'd like. But we didn't want to give up, which is why we wanted to look at, what other benefits of this service? Because we knew kind of innately we were doing something good here, and how do we prove that to our leadership? And that's why we're not ignoring readmission. We're not ignoring adverse events, but we're focusing more on patient satisfaction now. But having said that, because we still want to make sure we're not, that we're still keeping our patients out, we've started doing follow-up phone calls
That's great.
for the patients that are enrolled in Meds to Go, and seeing if that will maybe help move that needle. So.
That's great.
On the days that you would have an increased volume of discharges, like on a typical day of, like you said, 16, did you have any barriers with getting patients out efficiently or by that noon hour when most physicians want the patient out the door? And how did you deal with that on heavy volume days?
Well, that's a good point. At Gundersen, the time is more like 2 o'clock for whatever reason. That's kind of what we're looking at. And on those heavy volume days, a vast majority of them happen to be the ortho patients. Again, because they're scheduled, and they tend to schedule those surgeries on Tuesdays and Wednesdays, so they tend to leave on Wednesdays and Thursdays. And the ortho department, I mean, boy, they just exemplify how we'd like the service to run on the provider side, because we can't really dictate what they do, but they just happen to do it in a way that works really well with our service. And what they do is they put the orders in hours before discharge. They'll put the orders in, and they're pending. The patient has to complete therapies, physical therapy, occupational therapy, so we can get everything all wrapped up, and then we're basically just kind of ready to go as soon as we get the call that family is here, that their ride is here. So that helps out a lot. As we expand, I'm sure we're going to run into those busier days where we don't get that advance notice, and we typically are kind of the last person the patient sees before they get out the door. And so that has resulted in some, at times, frustration from the nursing staff, who are really told they need to get the folks out of the room. We've got 10 people waiting in the ER for a bed, that kind of thing. So that's something that we're constantly thinking about, but it hasn't been too much of a problem for us yet.
Here you go.
Just the question is for both of you. How did you do about if the patient has a question or had do a consultation about the medication you prescribe?
Like after they've gone home?
No, before when if they have a question, if the patient have a question about the medication, how do you communicate with the patient?
Well, we're right there. We're right there in the room with them.
So the pharmacist goes into
The pharmacist goes into the room and literally sits there with them. And it's great because if they're at the counter, I think patients often feel rushed, and quite frankly, so does the pharmacist. But when we're in the room with them, there's not that sense of rush. So I think they're more comfortable asking questions. And then oftentimes they have caregivers present too who have additional questions, and so we can really reinforce that.
In similar response with us, it's that they're up at that bedside or they're in our Plan B option. Unfortunately, they're going down to the retail pharmacy, and then that pharmacist can be easily pulled.
And how did you manage? You did not add any new people to the outpatient pharmacy? I mean, the pharmacists, when they are at the bedside, they're not actually in the pharmacy, right?
So at our pharmacy, it's a dedicated shift, so the expectation is that they are not part of the workflow, that the workflow can get done without that meds-to-go pharmacist. So at our site, we really worked probably for about a year before implementing the service, we really worked on efficiencies and just being able to do our jobs better and kind of anticipating essentially that feeling of a loss of a pharmacist. It was kind of slow going though, because at first we weren't that busy with meds to go, so that pharmacist would still help out. But yeah, now we've just kind of got the workflow streamlined so well that it really hasn't been a problem.
Thank you.
No, we haven't. I'm sure that information's out there, but we,
You want me to repeat it?
like time from discharge to the,
So, the time of delivery of medications, if it's shortened using the Get Well platform versus not using the Get Well
Right.
platform, or did you ever not use Get Well platform?
yeah, initially we didn't use the Get Well Network platform, but no, we haven't measured that.
We have a Meds to Beds program, and that's something that we're looking forward to having, is that shorter time between delivery of meds for the patients that elect to do it through Get Well.
Want to watch the video? Let's do it.
Oh, he's got it set up.
Yep, we're ready.
Any other questions?
Oh man, this is exciting.
Make it happen.
It's easy to arrange for a visit by one of our pharmacists. A hospital stay often means new medicine and changes in what you already take. Our Meds to Go service can make sure you go home with what you need to get well. Bedside Delivery helps get you home faster. You won't have to wait in line at your pharmacy or take a chance they might not have the medicine you need. Our pharmacists work with your doctor to find medicine that is safe, effective, and affordable. Those who care for you at home should know about your medicine, such as how it should be stored and when you should take it. Meds to Go accepts most private and government prescription plans. For your convenience, you can pay with cash, check, debit, or credit card right in your room. There is no extra fee for having medicines delivered to your hospital room. This is a one-time fill. We can send your hometown pharmacy an updated list of the medicines you take. We will work with your pharmacy to help you get the refills you need. If you prefer, you can use a Gundersen pharmacy for all your prescription and over-the-counter medicines. Many of them offer mail and home delivery at no extra charge. Our Meds to Go team will accept payment and deliver prescriptions in the comfort and privacy of your room. A pharmacist will review all new medicines, tell you when to take them, and answer questions. You will also receive information about safe medicine disposal. Gundersen pharmacies accept medicines that are out of date or no longer needed. This prevents accidental misuse of medicine and protects the environment. On your discharge day, you can leave with confidence. You'll have what you need to get better, and you won't have to stop at a pharmacy on the way home. Thank you for choosing Gundersen Health System.
That's awesome. And Rebecca, I'll ask a question because you're liable to get this question. I've seen this in a couple meetings that showed videos so far. You're going to have other clients reach out and say, hey, can we use your video? Or use your script for your video or anything along that line. So feel free to reach out to her on the app, but I don't know if you've had any hospitals already ask about this or not.
Not yet.
Oh,
Yeah.
it's for sale
You
over
have
here.
to go through Melinda.
All right, she's got her credit card machine out and ready. You guys line up over here. That's great. That's great. We appreciate it. We are a community here, and hopefully you guys have felt that at the conference. Is there one last question or not?
Was that a real doctor in the video? Looked like he was struggling.
He's a pharmacist. He's one of our pharmacists.
Awesome.
Yeah.
Awesome.
His name's Doogie.
All right, guys. So one last statement before we leave, before we dismiss out of here. Please join us in the Regency Room for final closing comments and a thank you. And one more round of applause for our presenters. You guys did a great job.